Hello, everyone, and welcome to this month's Simon Says Expert Series. I'm Dr. Greg Durm. I'm a medical oncologist, and I specialize in the treatment of patients with lung cancer and head and neck cancers. As a researcher, I lead lung cancer clinical trials as I'm interested in the development of new approaches to the treatment of this disease. We all want to welcome you today as this is Lung Cancer Awareness Month, and we wanted to take this opportunity to highlight the significant advances in both systemic treatments and surgical treatments over the last several years. Joining me today are my esteemed colleagues, Dr. Mimi Ceppa and Dr. Rohan Maniar. Thank you both for being here. Dr. Ceppa is a thoracic surgeon whose clinical focus is on general thoracic surgery, thoracic surgical oncology, and minimally invasive surgeries. Her research interests include lung cancer screening outcomes and tobacco cessation counseling. Dr. Maniar is a medical oncologist who specializes in the treatment of thoracic malignancies, including both lung cancer and thymic epithelial tumors. His research focuses on understanding and improving outcomes in patients with immunotherapy, and this includes investigating both the mechanisms that cause immune-related side effects and also resistance pathways in this disease. And with that, I'm going to kick it over to Dr. Maniar for his portion of the presentation.
Thanks, Dr. Durham. It's great to be here and talking about some advances we're seeing in systemic therapies for early stage lung cancer. So we can just move through to the next slide. Yep, so we're going to talk about some of the important advances that we're seeing in the last couple of years with regard to systemic therapies. Again, a really exciting time in lung cancer research. So moving on to the next slide. So just a little bit of background for everyone. Lung cancer is unfortunately the leading cause of cancer mortality in adults, both in the United States and worldwide. As you can see from the figure, the bottom panel, the leading cause of death in the United States with over 120,000 deaths and almost 1.6 million deaths worldwide. It has a high incidence with new cases over 200,000 annually in the United States. Despite these sobering statistics, we have seen that there's been about a 2% decline in incidence and almost 5% decline in mortality since its peak in 1991. And a lot of that can be attributed to two major things that we'll see on the next slide. So we can move to there. Two very concerted efforts, one in early detection of lung cancer, and the purpose of that being to use to try to implement curative intent treatments. And the other is research advances that have resulted in new and more powerful treatments for patients with advanced non-small cell lung cancer. And so these two facets have had a significant impact on mortality for lung cancer patients here in the United States. Just to go over some of the things that we think about when we see a possible lung cancer case, we're looking for two big things. Where is it coming from and what is the extent of disease? So we'll talk a little bit more about where it's coming from on the next slide, but in terms of extent of disease, we tend to look for the geographic distribution within the body for lung cancer. So lung cancer that's in one area in the lung or involving an area with some lymph nodes in nearby, we consider that to be stage 1 and 2, and the primary treatment for that is curative intent surgery. When we get more advanced disease, meaning lymph nodes and other areas in the chest, we still consider surgery, but oftentimes we're looking at chemotherapy and radiation together for the treatment. And when lung cancer goes outside the lung, whether it's in the space around the lung or into other organ systems, we consider that stage 4 lung cancer. For treatment options that are systemic, we kind of bucket them into three categories: chemotherapy, immunotherapy, and targeted therapy. And so when we go to the next slide right now, we're going to talk about sort of some of the things we're looking at when we're trying to understand who would benefit from immunotherapy and targeted therapies. So lung cancer isn't a singular entity. It's a sort of a spectrum of disease that encompasses many different subtypes. We ultimately categorize lung cancer into two basic buckets of non-small cell lung cancer and small cell lung cancer. There is sort of a couple of entities that sort of exist between those two buckets, and they have characteristics of both non-small cell lung cancer and small cell. But even within non-small cell lung cancer, we look at there are numerous subtypes, including adenocarcinoma, squamous cell carcinoma, and adenosquamous. And so, in addition to looking at the extent of disease, it's really important to understand from a pathology perspective, what is the cell of origin? We also look for other characteristics of the tumor, particularly PD-L1 expression, which is a biomarker for immunotherapy response, as well as genetic or molecular alterations, which is a biomarker for some targeted therapies. So for the purposes of this discussion today, I'm going to really focus on the role of immunotherapy in the treatment of early stage lung cancer. So if we can move on to the next slide. Perfect. So immunotherapy, you've probably seen a lot of commercials for it, encompasses a variety of different types of treatments. For this talk, we're going to really focus on immune checkpoint blockade, but there are a number of modalities that work to augment the immune system. There are cytokine therapies, adoptive cell transfer. Sometimes we refer to a version of that as CAR T therapy, and then cancer vaccines. But like I said, we're going to focus on immune checkpoint inhibitors. And on the right, you can see the number of agents that are available within this bucket. And you can have PD-1 inhibitors, PD-L1 inhibitors, and CTLA-4 inhibitors. And so there's a lot of complex interactions. We're gonna talk about that on the next slide, so we can move through about sort of how the immune system and the tumor sort of relate to each other. So if we can go to the next slide. Perfect. So this is a very complicated diagram of a cancer cell and the immune cells, the immune microenvironment. And what it's really meant to showcase or highlight is that this is a complex interaction. And so the cancer cell interacts with the immune system and vice versa to create an environment that ultimately allows the tumor to grow. I like to tell patients that we all have abnormal cells in our body, and our body, for the most part, does a good job of taking care of those cells and eliminating them. And it's particularly our immune system that is in charge of removing these abnormal cells. However, cancer, being built out of us, can hijack some of the machinery that we have to suppress the immune system. And so one of the ways it can do it is to express this protein called PD-L1. PD-L1 serves a purpose in all of us. It's to protect us from autoimmunity or self-reactive immune cells. Unfortunately, cancer can use this to then suppress the immune system from attacking itself. And there are a number of other checkpoint proteins besides PD-L1. But in this diagram, you can see that the immune system is not only interacting with the cancer cell, but other immune cells that are at the site of the tumor. And some of those are helping the immune system to fight the cancer, whereas other immune cells are actually working against the immune system to fight the cancer. And so it's a very complex system. We use biomarkers to help us understand which patients may benefit from immunotherapy, but we have imperfect biomarkers. And so we're just starting to scratch the surface on this complex interplay of cancer cell and immune cell. And I think as you're going to see through the remainder of this presentation, we're certainly expanding our armamentarium of agents to help us use the immune system to fight cancer. So if we can move on to the next slide. So immunotherapy has been revolutionary in the treatment of non-small cell lung cancer. And the reason it is because for prior to the emergence of immunotherapy, treatment has largely been chemotherapy based. Immunotherapy has the benefit of augmenting the immune system and the potential memory of the immune system to fight cancer. And so one of the distinguishing characteristics of immunotherapy is that for certain patients, a portion of patients that are treated, we see durability of response, meaning that some patients get treatments with immune checkpoint blockade and they have long-standing response to treatment that goes well into years. When previously with chemotherapy, we were sort of living in a world of months to year. years. So this is something that has been revolutionary in the treatment of tumors in general, but has certainly seen its place in non-small cell lung cancer. And you can see from this timeline, since 2015, we've seen the expansion of immunotherapy in patients with advanced metastatic disease. In 2015, it started with use of immunotherapy in the second-line setting, but it has since grown to be part of first-line treatment alone, in combination with chemotherapy, and even as combination immunotherapy with two immunotherapy agents. And so there's constant research into expanding the role of immunotherapy in the treatment of lung cancer. So what about using immunotherapy in early stage lung cancer? If we can move on to the next slide, please. So for patients with early stage lung cancer, data from a number of studies showed that chemotherapy after surgery can benefit some patients in reducing the risk of recurrence of disease and improving overall survival. So because of the advances we saw in the metastatic setting, it raised the question, well, can we improve things even more if we add immunotherapy to the treatments we're doing after surgery? So if we go to the next slide, we can see some of the studies that have come out in recent years that have posed that question. And so two studies, Empower 010 at the top, and the Keynote 091 study asked the question of whether adjuvant or after surgery and chemotherapy, immune checkpoint blockade with atezolizumab for Empower 010 and then pembrolizumab for Keynote 091 improved outcomes. And what we could see is that, yes, when we add immunotherapy after the chemotherapy, we see benefit for patients. And you can see on the Kaplan-Meier curves on the right that there's a separation between the patients that got atezolizumab on the top panel in blue versus those that just got the chemotherapy and then were on best supportive care. And likewise, we see that with the addition of pembrolizumab versus just chemotherapy by itself. The atezolizumab data is in patients who had that biomarker that I talked about, PD-L1 greater than 1%, whereas the pembrolizumab data is across all patients. So if we can move on to the next slide, please. So researchers wanted to venture further into the role of immunotherapy. And one of the questions that was posed and published very recently in May 2022 was, what if we give immunotherapy with chemotherapy before we do surgery? And can we improve outcomes in that way? And so this study, published in the New England Journal of Medicine, sought to answer that question. So if we go to the next slide, we can see some of the results of it. And largely, the results were great. It showed that we did see significant benefit when we added immunotherapy to chemotherapy before surgery when compared to just chemotherapy alone before surgery. And if we look at the subgroup analysis on the right, what we found was that for those patients who had that biomarker greater than 50%, or even moderately high at 1 to 49%, you can see that those were the patients that really had the greatest benefit. And so that's largely been our practice here at IU, is trying to identify those patients that would benefit from chemotherapy with immunotherapy up front to get these regimens versus doing chemotherapy with immunotherapy on the back end of surgery. So moving on so what are some of the pros and cons to neoadjuvant immune checkpoint blockade? Well, we know that when the tumor is at sort of a Goldilocks size, it allows the immune system to sort of be primed more aggressively for the tumor. We also know that patients, before they go for the surgery, are usually at their best in terms of performance status, so they're more likely to be able to go through the 3 cycles of treatment. It increases the rates of R0 resection, meaning surgery where the margins are negative, as well as giving us a very in-depth look at the tumor and the tumor microenvironment to understand if we needed to use chemotherapy or immunotherapy again, what are our expectations? Because we get to see how the tumor changes over the course of the treatment before we go to surgery, and then we can analyze that specimen. Of course, treatment in the neoadjuvant setting before surgery has risks associated too, and we try to balance out those risks and benefits when we're making the decision for a patient. One of the risks is the potential for delaying surgery. Because a lot of this data is new, unfortunately, we don't have long-term survival data yet, though we expect this data to come out in the next couple of years. And certainly any type of treatment has risks associated with it. And so any adverse effects may lead to cancellation of surgery, hospitalization, or even death. And certainly if disease progresses during the period when we're giving the chemotherapy, immunotherapy, it may be a situation where patients are no longer candidates for surgery. So we run the risk of potentially making a candidate for surgery no longer one. And as I said before, these are all the rationale for making a decision one way or the other about whether we pursue treatment in the neoadjuvant setting. Moving on to the next slide, we can see that after Checkmate 816, or even in parallel with Checkmate 816, there have been a number of studies that have sought to address this question of what is the best regimen in treating patients with early stage disease. What is the best combination of agents? What are the right patients for different types of different type of treatment modalities? We're hoping that these ongoing studies, and you can see a lot of them, I won't go into the detail, but they are looking at various iterations of treatment, will help us understand a little bit more about which patients benefit from which types of treatments, and those that may need another form of treatment altogether. These are still very much ongoing questions that are actively trying to be answered. But one of the other big questions and the implications of these types of treatments is what is the impact of these treatments on surgery and the outcomes of surgery? And so I think this is a good point to transition to Dr. Ceppa, who can give us a sense of what are these advances doing in the surgical management of lung cancer.
Thank you. Thanks for that awesome overview of all the past and ongoing trials of chemoimmunotherapy in the setting of early stage lung cancer management. So when we are talking about resection, really, the gold standard is a lobectomy. So this is just a diagram of all the segments, but really we're not talking so much about segments. We're talking about a lobectomy, so right upper lobe, middle lobe, or lower lobe, etc. And so if a patient was undergoing a lobectomy, say 20, 25 years ago, almost most certainly they were getting a thoracotomy. So an incision kind of like this, a little bit more posterior and underneath the scapula, but rib retractors, and splitting of muscles, which can result in crushing of nerves. And so patients would often have post-op chronic long-term pain management issues, a lot of hard recovery, et cetera. And so somewhere in the mid-90s, about two main surgeons in the U.S., and there are a handful of others as well, but there are two main ones who really started spearheading minimally invasive lobectomy, and that was Dr. Bob McKenna, who's over at Cedars-Sinai, and the other one was Dr. Tommy D'Amico, who was my mentor at Duke. And so instead of doing that, this is what we were doing, right? So 2 incisions, the largest one being 4 to 5 centimeters. This was an old photo, really, it's 3 to 4 centimeters if you ask me. And then basically the exact same surgery on the inside, doing a lobectomy, but with these small incisions. And so over the years, of course, we compared to thoracotomy, and this is just a landmark paper of the comparison, right? So before this, there were case series and large case series and in multi-institutional studies, but this one is using a national database, so the Society of Thoracic Surgery, the General Thoracic Database, and basically using propensity matching for comorbidities to compare lobectomy by thoracotomy versus by thoracoscopy. And so as you can see, chest tube duration, so the amount of days with patients with a chest tube, which is a huge cause of pain, was shorter for patients who had VATS lobectomies. Length of stay was shorter, and overall complications post-operatively was shorter as well. And over the years after that, we know there are a whole bunch of studies, and what we do know is patients recover faster even once they've left the hospital. This is particularly important in the setting of perioperative management because patients return to adjuvant treatment more quickly. They had fewer instances of missed doses and fewer instances of dose reduction in adjuvant therapy. This is if they had VATS lobectomy. Elderly patients, initially we looked at those over 70, had fewer complications when undergoing VATS lobectomy versus thoracotomy lobectomy. Octogenarians also had fewer complications, and in patients who had limited pulmonary function, as defined here, also had fewer postoperative respiratory complications if they had a thoracoscopic lobectomy versus a thoracotomy. And as you can see here, this is a diagram of the percentage of lobectomies performed in the country minimally invasively, which has been steadily increasing, and versus open, which has been steadily decreasing. So the challenge with thoracoscopic lobectomy, however, is that you're operating in a 3D dimension, but you're looking at a 2D screen. And so often surgeons were having a hard time converting from open lobectomy to thoracoscopic lobectomy. And somewhere in the early 2000s, Intuitive, which is the main robotic company currently, developed a very nice robotic platform whereupon we could do minimally invasive surgery. And what was the benefit there was wristed instruments, right? So instead of having straight instruments and having to play the game of angles, right, we had instruments that were straight, but at the tip of it had multiple angles of articulation, so it better simulated a human's wrist or a human's fingers in order to do the dissection. And so robotic thoracic surgery and robotic lobectomy started becoming more popular. And this is kind of what it looks like. So 4 incisions, 4 robotic arms, an assisted port, and then once the robot is docked, then the surgeon breaks scrub, sits at the console, and controls the robot. So here's the patient with the robot docked, and then the surgeon's using these controls to dictate what the robot arms are going to be doing. And so, of course, the next question would be, how does robotic lobectomy compare to thoracoscopic lobectomy and open lobectomy? This is a study that was recently published looking at exactly that. So using doing a retrospective analysis of 21 institutions and their data, they compared, and once again, propensity match, they compared thoracotomy lobectomy to thoracoscopic lobectomy to robotic lobectomy patients. And what they found was that in thoracoscopic and robotic lobectomy, chest tube duration and length of stay was shorter than for open lobectomy. Similarly, complication rates were less than with thoracotomy lobectomy. Length of stay was 1 day shorter for robotic lobectomy than VATS lobectomy. One can argue maybe that's just because we were moving patients along more aggressively as opposed to. But in any case, certainly at the very least, there's equipoise between robotic lobectomy and VATS lobectomy, and 5-year survival rates. So oncologic outcomes were the same compared to open lobectomy. So we're not compromising oncologic outcome in any way by performing these surgeries minimally invasively. And so similarly, as you can see, this is the trend. Conventional open lobectomy has been decreasing the number because, as I mentioned earlier, there's some difficulty in adopting and performing thoracoscopic lobectomies, but the conversion to robotic lobectomy kind of took some of those hurdles out of the way. So the number of robotic lobectomies are steadily increasing, and some of the VAT surgeons are now converting to robotic lobectomy. And so this is 2021 data. I believe the current data is that they're at least equal, or perhaps more robotic lobectomies are being performed than VATS lobectomies now. All right, so then what does this look like? This is purely for like pizzazz and interest. But anyway, this is a video.
The inferior pulmonary vein is dissected out and the branch draining the superior segment is identified.
So that's the inferior pulmonary vein. This is a superior segmentectomy that's being performed. And so that's the vein to the superior segment. It's being stapled. So we use a stapling device to both seal and ligate all vessels and parenchyma too. But
the lung is retracted superolaterally, revealing the bronchus. The lower lobe bronchus is dissected out and the segmental bronchus of the superior segment is identified.
so in
The
case
superior segmental bronchus is circumferentially dissected out and transected with a linear stapler with a 3.5 to 4.5 millimeter or equivalent load.
in case the sound's not transmitting very well, the next structure that we take after the vein is the bronchus, so that's the superior segment bronchus.
Further superior lateral retraction of the lung will reveal the pulmonary artery. The pulmonary artery branch to the superior segment is identified and circumferentially dissected out.
So similarly,
The fissure is then completed and the parenchymal margin is delineated.
the pulmonary artery is ligated.
This portion of the resection is completed with linear staplers with 3.5 to 4.5 millimeter or equivalent loads.
And the parenchymal margin is taken. And you can see here exactly what I was describing, right? The game of angles, right? Getting the right angle with only 2 incisions, whereas the robot has the ability to kind of twist around and accommodate angles.
The operation is completed with a mediastinal lymph node dissection, which we did not include in this video.
Right, and all that comes out, that's just a segment, a whole lobe comes out in a 3, maybe 4 centimeter incision. So I'm going to segue just briefly to lung screening, well, because we love lung screening, but also more importantly, because it actually parlays to what we're discussing. So this is the landmark trial about lung screening. This just to go, we all know this data, so I'm going to review it really quickly, but what the National Lung Screening Trial demonstrated was that the majority of patients who were being screened with CT imaging were identified at early stage compared to those who were being screened with chest x-ray were identified at late stage disease, which had a direct positive result in positively affecting lung cancer specific mortality. So a 20% reduction in lung cancer specific mortality, and because of incidental findings, a 6.7% reduction in overall mortality. This is a overview or table of other studies that echoed the exact same results in various countries around the world. But essentially, we know that screening for lung cancer is beneficial and helps to impact lung cancer mortality. Now, why it's important is because we are finding more and more small sub-centimeter or less than 2 centimeter nodules and cancers. And this is a study that was just recently published created quite a stir in the surgical world, but essentially looking at 2 centimeter peripheral nodules and comparing, I mentioned before that standard of care was lobectomy, but comparing lobectomy to sublobar resections. And the patients were randomized, multi-institutional. Their primary endpoint was disease-free survival. Their secondary endpoints were overall survival, recurrence, and pulmonary function. And as you can see in this graph here, the 5-year disease-free survival was the same in patients who had a sublobar resection compared to those who had a full lobectomy. Overall survival was the same. Recurrence was also the same. Pulmonary function in the immediate post-op period within 6 months of surgery was better for patients who had a segmentectomy, obviously because they lost less lung. This is an example of that concept that we are just identifying smaller nodules. So this is a lung screening patient, and this was what was found on lung screening. It was suspicious enough, but at the same time, if you can imagine, at the time of surgery, there's no way we're going to feel or palpate this nodule. And so, as another level of innovation in the surgery world, this is an example of how we identify such hard to locate, manual palpate these nodules. These are images courtesy of collaboration between pulmonary, Dr. Chris Canisi, and our new thoracic surgery faculty, Dr. Kyla Jobert. And as you can see here, Dr. Canisi used the robotic bronchoscopy platform to localize and inject a blue dye into that nodule that now we can see very clearly. These are the robot arms on imaging. And then similarly, a immunofluorescence dye was injected, and using immunofluorescence video filtering, once again, the nodule was clearly identified. And this patient then subsequently had a segmentectomy and did well. And so to bring it all back to immunotherapy, there are very few data right now to really know what the outcomes are surgically after having immunotherapy and chemo neoadjuvantly. This paper here said that about 90% of the patients had a thoracotomy. They could not do minimally invasive surgery in the settings. This patient was the almost exact opposite. They said 60 to 70% of the cases were being performed minimally invasively. And so the jury is still out on this question. So just as an example, this is a patient who had chemo immuno pre-op. This was the original cancer, and as you can see here, the hilar lymph nodes were positive. Post-op or post-chemo immuno, you could see that there was good treatment effect. The case was actually quite a nice thoracoscopic lobectomy, and the patient was a complete responder. The level 10 lymph node was also negative. She's had an awesome result. Here's another patient who has this large tumor, right? And so it was a squamous cell, PD-L1 expression was about 100%. This is pre-chemo immuno. Clearly had a fairly good response. It shrank quite dramatically. Okay, now the one thing I learned in this case, we started off thoracoscopically and then was able to get through about 50% of the case thoracoscopically. But the one thing I learned is if it was stuck on the PA before surgery, even with chemoimmuno, the tumor is still stuck on the PA. So it was a bear of a case. And this large tumor, as good of a response that they had, still ended up with a thoracotomy. Here's another example. Patient with 50% PD-L1 expression. This is pre-chemo immuno. This is post-chemo immuno, to my surprise, not even any response whatsoever. In the case or the nodule, the lesion, the mass was adherent to the azygous SVC junction pre-surgery, and it still was post, or not pre-surgery, pre-chemo immuno, and still was post-chemo immuno, also another bear of a case. So even though the jury is out, I guess my take-home point from these experiences is if it was a big tumor before, it's still going to be a hard case afterwards. And the patients who had smaller, more peripheral tumors, regardless of response, are going to be the ones who are going to be able to be managed thoracoscopically. And with that, I'm going to pass the baton to Dr. Durm.
All right. Thank you both. Those were amazing presentations. I'm truly in awe of what we've accomplished in lung cancer over the last few years and really excited to see what's ahead. And I guess that's a nice segue to this, is because I'm going to talk briefly about some of the lung cancer research that's available here at IU. If you can go to the next slide, please. So, I stole this quote from a colleague, but I think it works really well for what we expect to gain from research. Research is tomorrow's breakthroughs available today, right? And this is truly, I've seen this time and time again where patients have been generous enough to enroll in our clinical trials, and some of the things that we've been able to provide to them become standard of care later, and they were able to get these therapies a couple of years before they would have been available to them. So they're benefiting not only themselves in that case, but also future patients by helping us to answer some of these really difficult questions. And I just want to take a moment just to highlight, I know we have so many amazing colleagues across Indiana that provide such amazing care to their patients, but IU is the only academic institution in the state, and it's really the leading provider of clinical trials and research. And so we really want to work hard not only to ensure patients across the state, all Hoosiers, have access to our clinical research, but we also want to partner with those folks who are seeing them in the community to really encourage them to send patients to us so that we can provide those extra benefits to patients and to answer the cutting edge questions that are coming down the line. And then lastly, I think in case those who are on this don't know, IU has a really long and rich history of practice changing bench translational and clinical research, some of which have really changed the paradigm for treatment of lung cancer patients and many other types of cancer as well across the spectrum of not only the US, but also the world. Next slide, please. So I'm going to highlight 3 trials today, and then we'll move on to some questions. So the first, and all of these are early phase trials. We have additional trials in the metastatic setting, but because our focus really today was on early stage, we'll focus on that bit of research. So the first one is a collaboration we have with the Big Ten Cancer Research Consortium. That's just a group of academic institutions who all belong to the Big Ten Sports Conference. This first trial, we talked a lot about patients who have sort of stage 2 and 3, and even a little bit about patients who have larger stage 1 tumors. But what we don't have anything to offer except for surgery at the moment is for patients that have smaller stage 1 tumors. And unfortunately, those patients have much higher recurrence rates than you would expect. And in fact, oftentimes recurrence rates for small stage 1 tumors can even be as high as 20 to 25%. In the past, we've done trials of chemo. Those have not shown any improvement in outcomes for these patients. And so, with the advent of these immunotherapy agents, which we have seen are very exciting in practice changing, we wanted to look again at this population of patients with small tumors. So these are patients with lung cancer eligible for resection. Tumors are all between 1 and 4 centimeters. The patients get randomized to the immune therapy medicine pembrolizumab, and they only have to come once every 6 weeks for an infusion for up to 1 year. The other arm of the trial is randomized to observation. So that's the standard of care in this situation. And our hope is that by adding immune therapy to this particular population, we can lower that 20 to 25% recurrence rate and help our patients, even with small tumors, to live better. Next slide, please. This is a second trial looking at patients with stage 1B to 3. So we have trials encompassing the entire spectrum of patients who are resectable and potentially curable. This study really gets at a couple of different things. First, patients are taken for surgery and then are treated with standard of care chemotherapy with the addition of the immune therapy medicine atezolizumab. And then patients go on after 4 cycles to receive a full year's worth of immunotherapy. And really that's pretty much in line with what the standard of care is now, although we are adding the immune therapy with the chemotherapy, which is a little bit of a difference here. But what's really unique about this trial is that it uses a very, I think, will be important biomarker called circulating tumor DNA to try and see if we can predict which patients truly benefit, and also to try and see if we can determine, which patients really need additional therapies or how long that therapy should be. So in this trial, patients get their circulating tumor DNA checked. That's just a blood test, very simple. They get that checked at various time points, and we look to see if that circulating tumor DNA clears over time. And what we've seen in past studies is if we can clear circulating tumor DNA from our bloodstream, it's a very powerful indicator that patients will not have recurrence of their cancer. And unfortunately, the opposite is true as well. If that circulating tumor DNA persists, it's a very powerful predictor of whether patients will have recurrence of their cancer. So we're trying to look at this more closely to see how we can use it to personalize care in patients with early stage disease. Next slide, please. And then lastly, we talked a lot about surgical patients, right? But that's not all of the patients that we treat with early stage disease. Patients who have stage 3 disease that are ineligible for surgery for various reasons can undergo a combination of chemo and radiation, as Dr. Maniar said, with the goal of cure. Those patients get about 6 weeks of treatment and are then typically treated with about a year's worth of immune therapy. And that has really improved the cure of this particular population by about 10%, which is a huge change. But what we do know is that some patients can't tolerate immune therapy for a full year. Some patients don't want to get immune therapy for a full year. And so this trial really looks at trying to figure out what the optimal duration is. And once again, trying to see if we can use the circulating tumor DNA as a biomarker or as a test to try and give us some information about how long you, as the patient, should get your immunotherapy. So all the patients get chemo and radiation, and then everyone gets at least 6 months of the immunotherapy medicine. And at that point, the patients undergo ctDNA testing, and if their circulating tumor DNA has cleared over a couple of different time points, then the patients are eligible to come off of that immune therapy as early as 6 months. If patients continue to have positive circulating tumor DNA, they remain on the immunotherapy for up to 1 year. And really the hope with this trial is to try and figure out, if we can use this biomarker to optimize the duration of therapy for each individual patient rather than prescribing everyone the exact same amount of therapy. Next slide. I think that may be the last one. So I think it's time just to move to some questions. If you have some questions, you can sort of enter them into the chat. I have some that were pre-submitted, so we'll just start there and we'll keep an eye out for new questions as they come. Dr. Ceppa, the first question actually that we received was about screening. And I think it's a really interesting question. So if you knew as a child that you were around parents that smoked, exposed to this, and I think also just to take that a little further, if you're a patient even as an adult who's exposed to a lot of secondhand smoke, is that an indication that you should be screened?
Right. So as of right now, the best data we have is all the various lung screening trials and the patients who they categorize as being high risk of developing a lung cancer are those who are former smokers and based on various pack years, et cetera. And so a history of childhood exposure, not a personal history of smoking, is not a direct criteria for lung screening right now. There are no data to support this because you have to think about this, right? In the end, we're not just doing a small thing. We're talking about getting a CT scan every year for several years until you don't follow or meet criteria anymore, right? And that's not without its own harms, right? And so as of right now, childhood exposure isn't alone in and of itself a reason or an indication for lung screening.
Okay. And sort of as an extension of that, that question also asks, is there an age at which lung cancer screening is too early or even one that's too late, right? Is there a cutoff in age for patients where it's not helpful?
Right, so good question. So once again, we go back to the study criteria, right? So for the National Lung Screening Trials, 55 to 77 years old. Since then, we've expanded criteria to 50 years old, and so younger, but not before, right? And USPS task force has recommended screening through 80 years old, right? So it has expanded the criteria a little bit. But that being said, not much sooner than 50, and certainly after a certain age, then the benefit of getting screened, right, uh, outweighs the likelihood that a patient might have some other event.
Absolutely. And I want to ask another question. This is Lung Cancer Awareness Month, right? This is a time when we really want to talk about the advances, but we also want to talk about the challenges, right? And I think either of you can answer this question, Dr. Maniar, Dr. Ceppa, but there's a big stigma that surrounds lung cancer, right? In breast cancer, we do a great job of screening those patients. Colon cancer, we do a great job of screening those patients. In lung cancer, we're only screening about 6 to 8% of the patients who are eligible for that. And I think some of that may have to do with stigma. How do you think stigma affects our ability to treat and detect these cancers early? And what do you think we can do about it?
Yeah, I think there's a. I'll take a first shot at it, and then Dr. Seppa can help me out. But I do think there's certainly a stigma around lung cancer screening, and then even coming in for treatment after the diagnosis. Ultimately, takes a village, right? It takes the community to come together, family members and friends to say, for patients who are at higher risk, as Dr. Seppa sort of delineated, it's important to get screened because we have so many great treatments that we can do now upfront. Patients are living longer. Quality of life is improved with the introduction of our targeted therapies and immunotherapy. And now is just the time to get screened if you are within that category that needs to be screened. And I think it's something that we have to do on the state level, from a federal level, but really it comes down to the community. We just have to look out for the people in our community and make sure that everyone is getting regular checkups with their primary care physicians, that they're getting plugged in with screening resources to help them find the place to get a scanner and do all those things so that we take the burden off of one person.
One of my colleagues brought this up, and I thought it was a brilliant or way of illustrating it. Right, when a patient has colon cancer, we don't sit there and say, "How much fiber do you eat? What do you eat? How much fat is in your food?" Right? Or if a patient has breast cancer, they don't question, "Now, were you on OCPs or whatnot?" Right? So that whole like you said, stigma that patients who have smoked kind of cause this. That's absolutely hogwash. A cancer is a cancer. Number one, we've all treated patients who've never smoked, have never been around or exposed to cigarette smoking, and also developed lung cancer. It is what it is, and we have to take care and treat it. We don't shame other patients of other cancers because of lifestyle choices, and we shouldn't do this for lung cancer either.
Thank you both. Those are fantastic answers. I can't agree more with all the things that you said. Another question just came through the chat, and that's, could you elaborate on what does secondhand smoke really mean? When we say secondhand smoke, it may not be obvious to everyone what that means. Could you elaborate a bit?
So not direct smoking, but basically being in the environment, right? So being a child who never smoked personally, but parents are smoking within the same household, so you get the secondary effect to that. Or I've never smoked, but that being said, I've been to bars before smoking ordinances existed, and I've certainly been exposed to secondary smoke. So that's essentially what we're referring to.
Yeah. Thankfully, it's changed so much, right? We're not exposed to it as much especially in the community. Well, I wanted to switch gears. We talked about a lot of other things that, that talk more about treatment of these cancers. And Dr. Maniar highlighted a lot of these new treatments. And, I think sometimes as a medical oncologist, I look at that table he provided for us, and it's a little bit overwhelming. Dr. Maniar, how do you think we're going to choose? And I guess more importantly, is one trial going to answer the question for all patients, or do you think we're going to have a number of different approaches for different patient populations?
Yeah, I think it's going to be the latter. I think all these trials have come out. A lot of those trials that I put in the table actually have read out already with, positive results in a number of them. And a couple of those trials at the bottom were actually phase 3 confirmatory studies that will probably get indications, FDA approval. The Keynote 671 was also, recently approved. And so these are, we're never going to get sort of a great answer about which regimen is the right regimen for all patients, and even more so, which regimen is the right regimen for the particular patient in mind. These trials tend to be sort of bucketing a lot of patients together. They're not necessarily personalized in their approach, meaning they're applying a very broad strokes treatment modality to a large swath of patients, and it's ultimately going to be up to us as clinicians and patients themselves to sort of come together to make a decision about what regimen looks right for them. And then certainly the adaptability of, if we do neoadjuvant approaches where we're giving chemotherapy with immunotherapy up front, well, what do we do after the fact, after we get the surgery? If we don't get a complete response from pathology, is there something we can do on the back end to help reduce the risk of recurrence later on? These are all ongoing questions. I hope that some of these get answered, but ultimately, the way science is sometimes we don't get the exact answer we're looking for, but we're able to adapt and sort of extrapolate from the data. More data is generally speaking helpful, and so I think as these trials start reading out more so, I think we'll be able to answer some of these questions.
Okay. And to kind of piggyback on that, I mean, it's not just immune therapy. We didn't get a chance to talk about this because it's almost a whole nother Simon Says in its own, but targeted therapies and genomics have become a big part of what we do, particularly in metastatic patients. How is that affecting our choices in early stage lung cancer, and what therapies are coming down the line for those patients?
Yes, so we know that for EGFR mutated lung cancer after resection, the use of osimertinib, which is a EGFR tyrosine kinase inhibitor, a pill that you take, is now standard of care for use after surgery. We know that there are a number of other mutations with ALK fusion, ROS1, and just a bevy of other molecular alterations that we have treatments for in the metastatic setting and are actively being evaluated in the perioperative setting. And the hope is the same with immunotherapy, that we provide better results from surgery as a result of these drugs, that we provide greater time from recurrence or longer or better cures. And I think as our understanding of the molecular alterations increases, we were talking about this in clinic today, the things that we see but we don't necessarily know what to do, in the next 5 to 10 years, we're going to have more treatments for that. And so we can move to personalize medications on a molecular level for each patient. I think that's the goal. We personalize approaches for patients across immunotherapy and also in targeted therapy too.
Fantastic.
I was going to just add in really quickly. I think the take-home message here is really that the landscape is changing dramatically. It has changed in the last year in a miraculous way. It is still evolving, and really the most important thing is that the collaboration between surgery and medical oncology and radiation oncology in the management of these patients, because the target's continuously moving, right? And you alone can't do it. I alone can't do it. We have to work well together to kind of figure out what the best algorithm or personalized care is.
Dr. Ceppa, you read my mind. I was going to ask you how all these changes, because the paradigm just 5 years ago was so much different, right? Patients came to surgery and then, we talked about therapy afterwards, but now it's so much different. How's this really changed the multidisciplinary kind of flow of things? And my other question for you, if you could answer, is, how has immune therapy changed I know we don't see a lot of changes to these sort of tangential or tangible outcomes, but do you see a degree of difficulty that changes in the surgery itself when patients get immunotherapy?
Right. So to be back to the original point, which is the whole, you're right. Before we used to work in silos, right? So stage one, surgery. Stage two, maybe surgery. Maybe I'll collaborate with you a little bit with adjuvant therapy, but I really didn't see the patients afterwards, right? And then obviously stage 3B and higher, I never even saw, right? So now I think the landscape has completely changed. I think all patients should be evaluated by the true multidisciplinary team, so we can decide, is this patient a patient we're going to do surgery first, and then go, then have adjuvant care, or is this a patient who would be a neoadjuvant candidate, and then et cetera. So that I think all programs should start evolving to move in that direction. And then also to make sure that we send the path specimen for the right test as well, right? Now, to answer your question about immunotherapy and how it's affected us from a technical standpoint, I mean, I kind of tried to illustrate it with those CT scans, right? I mean, our N is still not that high, but it hasn't made any, well, in some cases, it's made surgery more challenging just because the tissue planes are more sticky, but that can also be a phenomenon of we're in Indiana, right? In other scenarios, when the tumor shrinks very nicely and it's already a peripheral lesion, no problem, right? On the other hand, as I mentioned, if it was a big tumor before, there's really, I don't think now, I shouldn't have the false hope that a good response means that it's not going to be any more stuck or any less stuck to the airway or critical structures like the pulmonary artery, et cetera. So more to follow, I suppose, once we have more experience of this.
Great. All right, last question, and we're going to wrap it up. This goes for both of you. One is, what do you think is going to be the most impactful change over the next 5 or 10 years? And what are you most hopeful about in lung cancer research and treatment? Dr. Maniar, you go first.
Yeah, I think the most impactful thing will probably be generally it's going to be understanding molecular alterations in the immune microenvironment to a degree where we're personalizing approaches. So, rather than, so when I look at 5 years from now, it's going to be getting all this data, a lot of data, putting it together, and having AI, having algorithms that we're building out sort of populate like what the best approach looks like based on all this information. Kind of like the way breast cancer uses a bunch of characteristics in the tumor to sort of point who needs this versus who needs that. I think we're on that way to getting that approach to lung cancer treatment.
Right.
And I would agree. I was actually going to use that as an analogy when talking about the more multidisciplinary approach to early stage lung cancer, is it's becoming more like breast cancer. But the ideal would be that we literally can cure all cancer, right? That later stage disease is now going to become, because of treatment, right? More surgical, amenable to surgery and resection and cure, and that early stage disease will be completely eradicated with a combination of surgery and chemoimmuno or targeted therapy.
Yeah, thank you both. I think the future of lung cancer research and treatment is bright, right? I'm very excited to see what will come over the next 5 or 10 years. I want to thank you both for your presentations. I want to thank everyone who's on this for joining us for this month's Simon Says. A reminder that you can find a recording of today's session and information about upcoming sessions at cancer.iu.edu/Simon Says. Thank you so much for joining, and have a wonderful rest of your day.
Thank you, everyone.
Thank you.